I'd like to thank Dr. Rishi and my previous speakers for making DSEC and DMEC sound very easy. So I'm going to be talking about PDEK, and I think they've covered all the basics. So I will just go to the... It's not shifting. My slides are not changing. Excuse me? Slide is not changing. It's not changing. Yeah. So the advantage of PDEK here is because we use the duas layer, I am getting an additional 12 microns of tissue there, which makes my graft a little more sturdy, easy to manipulate. And I do get to use the younger donor tissues, and the advantage being a higher specular count to start off with. But one thing, like Dr. Rishi mentioned, if you don't get a bubble in one eye, the pair eye is going to behave similarly, so please do not go for the pair eye. And since we're dealing with younger donor corneas, we will end up getting a tight scroll, unlike a DMEC graft. And these are just some of our pre and post-op pictures. And so we do PDEK in almost all cases, even if it is an ACIOL explantation with a gluteal SFT PDEK, and post keratoplasties like a failed PK or a TPK, we still go ahead and do PDEK if there's not too much of a scarring. So three things you will have to, at least four things you would have to remember when you're doing a PDEK. The main things are the bubble, achieving a type 1 bubble, use of an air pump, which really helps to solve your problems, and the use of an endo-illuminator, like Dr. showed in her DSEC surgeries, how she uses it, and the graft unrolling technique. So, so this is how a type 1 bubble forms. So the graft is inverted. You use a 30 gauge needle and a 5 cc syringe. You just enter inside beyond the, just behind the limbus. And as you go inside, you should just make sure your needle is angulated very superficially so that you achieve a type 1 bubble. And a type 1 bubble typically forms in the center going towards the periphery, and it doesn't expand beyond maybe a 7.5 to 8. I'll just skip this. So there are different ways in which you can achieve a type 1 bubble, and this is the injector. We don't use the glass injector. This is just an MIL injector which we use. We take out the spring and the sponge tip, and we stain the graft again. So the graft is stained for 2 minutes because we need proper visualization inside. And once you are sure of the scroll, like the bicep curl, and you can just guide the graft into the cannula and load it into the injector. So we just keep it inside the bowl, and I'm touching just the stromal side, and once it's inside, you just guide it inside. And yeah. So I will just show you the uses of the air pump. So the reason for using an air pump is a descemetorrhexis under air is much easier to visualize, and it acts as a third hand for us. Sometimes when there's a bleed after your PI, it helps to tampen out that, and these are the advantages of using an air pump. And I would just go to the main, I'll just show you a case, and we'll discuss all the steps in that, So this is a simple PDEK case, case of a PBK. So we first put in a side port entry and pilocarpin to constrict the pupil. If I feel the pupil is not constricted enough, then maybe a pupiloplasty. And I put in an air pump there. I make a partial entry and use my cutter to make an inferior PI. And once the entry is made, PI is made, I change it to air. And then I do the descemetorrhexis under air. And you can see that the margins are very well visualized under air as compared to saline or visco. And so once you achieve your descemetorrhexis, I would give a little saline wash just to make sure there are no tags remaining over there. And once the scrolling is, once I've stripped the DM, I make a full entry, and here I'm peeling off the epithelium because sometimes the visualization is better when you take off the epithelium. And this is the same thing, the graft being loaded again into the injector. And ideally, when you try to inject it into the eye, you would like to keep the orientation in the same direction. But like you have your normal IOL, sometimes if you feel it's in a different direction, you turn your hand. You could do that with the grafts here. And once the graft is inside, like all surgeons say, your chamber has to be shallow so that it's easier to unfold the graft. So I'm using the endo-illuminator just to identify the scroll. We don't stamp our grafts, it's only with the stain. The small air bubble in the center has helped me to open up the graft much easier. It was unintentional, it was just there. But we tap the graft, and unlike a DMEC where we expect the entire graft edges to unroll, in PDEK the advantage is I can, even if I have a small graft fold at the edge, I can still go ahead and inject air and I can float the graft. Because I have the advantage of putting in an air pump and always suture the main port just to make sure that, you know, by mistake your graft doesn't slip out while you're manipulating there. I put in the air pump again, and you keep the pressure at 30 because, and you can see me unfolding the small edges at the periphery. There's not much of cell loss in these cases because we use very young donors. This is probably a 20 or 30-year-old donor. And we use very minimal touching at the periphery, and that is how we finish a PDEK case. And once all the sutures, the ports are closed, we remove the air pump and close it with air. Patient lies supine for an hour. And this is another case of a scarred cornea, but this was more of a hypertrophied epithelium. So once you peel it, it's again like a regular PDEK case. An ASOCT helps in these cases, but we always have a backup PK tissue just in case the scarring is too much. I would convert it to a PK. So the steps are the same, and this is one last case I would like to show. This is a case where there was an optic capture and there was a broken haptic in this case. So in this, I'll be showing you all the techniques which we do, basically a glued IOL, an IOL explant, then you follow it up with a pupilloplasty and then a PDEK. So initially in the learning phase, we used to do them as staged procedures because we didn't want the graft to suffer too much damage with iris tissue handling, but over a period of time we managed to do them all in the same setting and the results are great. So this is again just trying to do a scleral tunnel to exteriorize the IOL. Sorry. How can I forward this thing? I need to forward it a little. Yes, no. I say play kar do, no problem. I'm so sorry for this. Forward नहीं कर सकते हैं इसमें. हाँ, वही मैंने पूछा था ना आपको. Sorry, I'm not able to forward this video. If we have time, I'll play it. Otherwise, I will just conclude my session. So, I can? Yeah, I have it separately. मेरा पेन ड्राइव कहाँ है? इसको डाल सकते हैं इसमें? आ रहा है वहाँ? It's playing here. No? Yeah. But where do I? How do I forward it? That's the whole point, no? So that was so initially we took out the broken haptic and then we exteriorized the entire lens there. And then the glued IOL technique, I think everybody is well versed with that by now. And we use a single pass 4-throw pupilloplasty in all these cases where we have this bad iris tissue, because again with a gluediol we have this problem with air escaping behind, and then the next day the chamber is shallow with the graft stuck there. So pupilloplasty is very versatile. You can use it in any direction you want to close everything, but only thing is you have to be careful about how friable your iris tissue is in these cases. So once you achieve a decent pupil over there, so that requires multiple pupilloplasties there, and once I've secured the glue, then I start with my PDEK, again putting in the air pump and scoring the DM. All the techniques are the same. I use the same SICS tunnel to load the graft inside the patient's eye. So once you put it in, the only difference in gluediols when you do, the chamber will not shallow as easy as your other eyes, and it will be a deep chamber for us, so you have to continuously keep egressing the fluid out. And like I said, the advantage again is even if it is decentered or there is a little fold, I can always put in air, and then with the help of an air pump I can move around my graft, and once I feel it is centered and all the folds in the periphery have opened up, I can close all the ports and remove the air pump. I prefer to keep the air pump at a higher pressure. Once the entire graft is opened up, keep it like that for 5 minutes and then close the ports. So this is the end of the surgery. Thank you so much.
Thank you, doctor. Thanks.